thank you very much for joining us today for our BRCA Q&A webinar. So just to introduce myself, my name's Jo Stanford, and I work for Ovarian Cancer Action, the Cancer Prevention Officer. Just a bit of context as to how I ended up in this role. I actually inherited a faulty BRCA1 mutation myself from my mum, who had ovarian cancer and sadly passed away. And I found out about that in 2011. I had a risk-reducing mastectomy in 2014 with reconstruction, and I'm planning on having my ovaries and fallopian tubes removed this year. It was supposed to be sometime around now, but you know, clearly a lot is happening in the world at the moment, and like a lot of people, that's been delayed. So my role at Ovarian Cancer Action is talking about BRCA and genetic mutations, helping raise awareness of the importance of knowing your family history and so on. I'm really, really lucky to be in a role that allows me to do something that matters so much to me. So that's me. As I said, Tori's on the line as well. So if you have any issues whatsoever, please get in touch. Her number is in the emails, as I said. And we also have Angela here, Angela Brady. So hi, Angela. Thank you so much for joining us. So Angela is a consultant in clinical genetics at Northwest Thames Regional Genetics Service. So she's here today to answer all your questions about BRCA, genetic testing, cancer risk and so on. But I do want to point out that this isn't a medical consultation. So Angela won't be able to offer kind of personal medical advice to you. And we should say, as always, that if you do have any specific personal questions about your situation, please do speak to your medical team, but hopefully Angela can answer lots and lots of questions generally about genetic testing and so on. So in terms of how the webinar will work, today in the webinar you'll be able to see myself and Angela, but not each other, and everyone is on mute at the moment just to limit background noise and so on. We are recording the session just so that we can share it with you and anyone else that might find it useful in the future. But the important thing there is please don't feel you have to take lots and lots of notes or anything like that. You can listen and we will be able to send you the recording later on. You should see along the bottom of your screen there should be some buttons. So you should see chat, raise your hand and Q&A. So please use the Q&A function to send in all your questions for Angela, any questions that you do have. You can ask those anonymously through the Q&A, but either way I won't read out your name, so that won't be on the recording or anything. So please do take advantage of being able to ask any questions that you might have. If you're on the phone, I'll try and make sure at the end that we give you an opportunity as well to ask any questions. For the chat box, please use that if you have any comments for us or Angela or for anybody else on the call to see, or if you've got any comments or want to share any of your experiences. We've also got, as I said, a raise your hand button. So what will be really useful for Angela and myself to get an idea of the audience that we've got here, if you're comfortable to do so, please could you click raise your hand if you've already been through genetic testing and know that you carry a faulty BRCA gene. That would be really useful if you could do that just now. I can see some people raising their hands. Thank you very much. Brilliant. That's really useful for us to know, to kind of have a bit of context there. So this webinar is one of a series of workshops and webinars as part of the joint Staying Connected project between Ovarian Cancer Action and Overcome. We've got lots more sessions coming up. As you may already know, we've got a BRCA workshop next Monday on the 11th of May about starting a family and all the issues around that. We've also got other sessions including the menopause. I think that one's on Wednesday, which I'm going to go along to myself. And we've got crafting workshops, exercise workshops. Please do take a look at the programme that's going on because there's lots of stuff going on there to sign up for. And we've also recently set up a monthly e-newsletter specifically for people with high genetic risk. It started out, it's updates on the COVID situation, how that's impacting people, but ongoing we want to keep that going to give you an opportunity to have updates on research, guidelines and so on. So we'll send the link to that through in kind of the roundup people after that. As I say, I will try and get through every question that's sent, but if I don't have time or if for some reason I miss your question, please do get in touch. It's brca@ovarian.org.uk and I can follow up with you afterwards. So thank you so much again, Angela, for joining us. It's really, really helpful to have yourself on the call. I guess something that will be on lots of people's minds at the moment, because we do have the majority of people on the call today have already been through genetic testing, and so will know about their higher risk, is how is the current situation with coronavirus and so on impacting genetic testing and screening and surgery and so on, and should any of us be worried about any of that and the delays involved?
Hi there. Thank you for inviting me. So obviously it's a very different time at the moment in view of the virus, and things are just changing day to day. There seem to be sort of constant updates about what's happening. At the initial lockdown, certainly in terms of the genetic testing, the lab was very much likely to be, our lab was going to be involved in doing the COVID testing, but actually that sort of changed. So initially we weren't accepting any sort of routine referrals. However, now, and they were only accepting urgent referrals, but actually now the lab has, as of last week, been accepting routine referrals again. So things are just changing on a day-to-day basis, really. I think I know that we've received sort of notification from the different cancer networks about screening and about changes potentially to therapies, and sometimes instead of the chemo going more towards the surgery line of things. However, I think that's just changing so rapidly. It looks like things are starting to get back, or aiming to get back more towards normality, certainly in terms of the genetic testing side of things. So hopefully the screening was put on hold, but hopefully that will start to come back in. Certainly anything urgent is getting done. One of the things I do is a renal genetic clinic, and if we need those scans doing, we can get those done and things. So almost the hospitals have put things on hold, obviously to try and only do urgent things and prioritise COVID-19 patients. But I think things are going to be, it's meant there's been sort of facilities within the service to, if there is anything urgent, for that to get dealt with. But I think that hopefully the screening service, which was put on hold, I can't answer for exactly when that will start again, but hopefully it will. And we've been going as a genetic service, been carrying on, but everything non-face-to-face. So one of the things that does happen, in which some of you may have been tested through, is the mainstreaming, where the genetic testing is done by the oncologist who you're seeing, rather than a geneticist, and the lab hasn't been accepting routine samples from them, just from geneticists. But going forward, I think it's going to get back much more to normal.
Thank you. That's really useful. And I think it's really positive to hear that already from your end, things are starting to seem to be going the right direction at the moment. So I know in terms of screening itself, the situation in England is that it's on a local level, that things are based on what staffing and so on they have in. Scotland and Wales did cancel all screening. But what we did hear last week on the NHS England call, for anybody who's interested, is that as things pick up to become go back to normality, and appointments start being picked up again, at the top of the list in terms of who should be getting screening are people who are at the highest risk, such as those who've already been through genetic testing. So that has been recognised by NHS England as the priority to get back to normal, which is really useful to know. So we have already had a question through, Angela. So the question is, having BRCA1, I have had ovarian cancer. Why do some people get ovarian cancer and some people get breast? And what are the risks of breast cancer having had ovarian cancer already?
Okay, so if you have a BRCA1 gene, then the risks of breast cancer, there's sort of a range of risk of breast cancer which is given. Historically, it was up to about 90%. More recent figures are suggesting up to about 72% lifetime risk. So if somebody has BRCA1, the main risk is breast and ovarian cancer for females. And so if you've already had the ovarian cancer, then depending upon your age, you will have outgrown some of the risk of developing breast cancer. So usually about the sort of 5-year interval for getting breast cancer is about 5%. So half the risk of breast cancer is under the age of 50, and half that risk is over the age of 50. So as we get older and we haven't developed any cancer, the sort of overall, the remaining lifetime risk goes down, but there's still a risk. So for females with the BRCA gene, there's things that can be done, obviously, with either to have routine screening, which we know actually does work with mammograms, or under the age of 50 with MRI. But some people choose to have the risk-reducing bilateral mastectomy as well. So, but that said, some people who've got a BRCA1 gene don't get breast cancer. They have ovarian cancer, but there's still a chance, because So if you have 100 women and the lifetime risk of breast cancer, say 72%, that means 28% wouldn't develop breast cancer over the lifetime. So it is possible to have the BRCA gene, to have had ovarian cancer, but not to definitely get breast cancer. But there is still a significant risk of breast cancer compared to the general population.
Brilliant, that's really useful. And if someone had already been diagnosed with breast or ovarian cancer but hadn't had genetic testing, should they be offered it in this country now?
Yes, so anyone with, it depends on the type of ovarian cancer, but yes, certainly for high-grade serous non-mucinous ovarian cancer, everyone's eligible for BRCA1 and BRCA2 gene testing. Brilliant. Yeah, and then if it's just breast cancer, then it depends upon the family history.
Okay, brilliant. So a common question around kind of inheritance and so on is around whether children being able to inherit BRCA gene mutations and whether BRCA can skip a generation. I don't know if you can talk a little bit to that.
So the genes are, it'd be a shame I haven't got a picture. Well, I could show you a picture, but I don't know how good that would come across. We have 2 copies of each gene. We get one from mum and one from dad. And so if we have a normal copy and a faulty copy, when we make our offspring, there's a 50-50 chance of passing on either the normal gene or the faulty gene. So if we pass on the faulty gene, then that child will have a risk of getting breast and ovarian cancer. But if we pass on the normal gene, then that child isn't at risk, and that child can't then pass it on to their offspring. I know sometimes people think there's been a skip, but it's basically because the genes, they're not always penetrant, meaning even if you get the gene, you don't definitely get the cancer. So it can look like somebody's not got the cancer, even though not got the gene, even though they have got the gene, it's just not manifested in them. And that's the reason why, when we look at these families, we see some families where there looks to be loads of people affected, whereas other families, it's much less of a strong family history, even though the gene is there. So to sort of rationalise who we test, there have been criteria decided, and one of the criteria is non-mucinous ovarian cancer. That's recognised that if you do have that diagnosis, probably the chance of having a BRCA gene is around 15%. So that's why that group alone is eligible for testing. But in general, on the NHS, you're eligible for testing if we think there's at least a 10% chance we might find BRCA1 or BRCA2. But the chance of finding it goes up the more people, the earlier the age of onset, and if there's pattern of cancer, so if there's breast and ovarian and pancreatic and prostate, it makes you think much more likely it's BRCA.
Brilliant, thank you. We've got another question in talking about prostate cancer. So, for example, in other countries, it's a lot more talked about with significant increased risk for prostate cancer. Specifically, in this question, they're asking about BRCA1 compared to the general population. And the question is saying, why does the UK have no high-risk screening programme for men in terms of prostate cancer?
Yeah, no, I mean, a screening program has to be something that's sensitive and specific, and I think that just hasn't been found for prostate cancer. We do prostate cancer screenings recommended for men with a BRCA2 gene variant. There was initially thought that BRCA1 was associated with a higher risk of prostate cancer. It possibly is associated with a slightly higher risk, but not as compared with BRCA2, where there's thought to be a 25% lifetime risk of prostate cancer compared to sort of an 8% in the general population. So for men with a BRCA2, we do recommend that they have prostate screening through the GP with an annual PSA measurement, prostate-specific antigen measurement, and then if that's raised, that they then see appropriate urologist. In time, I think there are different studies ongoing to try and work out about prostate cancer screening, and in certain different population groups, there does seem to be a higher risk of prostate cancer. There's quite a lot of prostate cancer research that goes on through the Marsden Hospital. So in our region, if we do see a family history where there's quite a lot of prostate cancer, we might be able to refer to them to look for to get involved with studies there.
And talking about screening, that's the similar situation with ovarian cancer, isn't it?
There isn't proven screening for ovarian cancer at the moment. So genetic centres were involved in the large study, the UK Familial Ovarian Cancer Screening Study, which took place over a number of years, and it didn't show that there was a definite advantage to screening for ovarian cancer. So and that was measuring CA125 on a 4-monthly basis, and then if the CA125 was going up, then an extra ultrasound examination was done. So we're still there isn't a good screening mechanism for ovarian cancer, so the recommendation is still to have the risk reducing surgery to remove the ovaries and the fallopian tube.
Brilliant. Another question we've had in relates to breast cancer risk and the size of breasts. It's not something that I've necessarily discussed before in my discussions with genetic cancer and so on, but the question being, does the size of your breasts impact your breast cancer risk? Oh, I think we may have lost Angela for a second there. That's okay. Angela did warn us that occasionally her Wi-Fi. There you go. Are you back, Angela? Okay, I'm going to let Angela log out and log back in if she needs to. Oh, we're back.
Sorry.
That's okay.
That's the Wi-Fi. Sorry.
Did you catch that question, Angela?
Sorry, Wi-Fi cuts out after about 30 minutes, I'm afraid. So I'm on the non-Wi-Fi now. So sorry about that. Hi. Can we just
So the question was around whether if you have smaller breasts, you'll have a lower breast cancer risk just to having a lower volume of cells.
I missed that totally, and also the last bit probably. I'm sorry.
Whether your chance of breast cancer is related to the size of your breasts, and
No. I don't think there's any. I'm not aware of any evidence of that. Are you aware of any evidence of that?
No. As far as I'm aware, in terms of the size of your breast related to fat stores rather than breast cells itself, isn't it? So the fat cells are probably not where the cancer starts. It would be in the the breast tissue itself.
Yeah, in the ducts or the lobules. But yeah, no. So
I guess there might be something there in terms of how easy it is to check yourself when you have less tissue to check, I guess. I don't know if there's any, we'd have to go away and look up some, whether there's any studies on that in terms of whether it's easier to self-check at home yourself if you have smaller breasts. I guess that would make some sense, but I don't have any data on that.
No, I mean, for men, obviously there isn't, when a man has a BRCA gene, we don't recommend that they have an MRI or a mammogram, but we recommend that they self-examine so that they look at their chest and feel their chests. But obviously if they did find a lump, then they may then go for a more detailed screen.
And I think that's something that we always try and talk about at Ovarian Cancer Action as well. A lot of people, even when you've already been through genetic testing, don't necessarily realise that the men in your life, if they carry the same, faulty gene as you, they will be at increased risk as well. So like you say, BRCA2 positive men need to be aware of breast cancer particularly and checking themselves, and we know that the survival rates for male breast cancer are quite low because men assume that they can't get breast cancer. So it's something that's worth having a discussion with any men in your life who have been through this process already. A specific question here, so talking about different risks published in different countries. So for example, in Canada, it's said that men with BRCA1 have an increased risk of breast and prostate cancers, but here we don't say that they have a significantly increased risk. Also in Canada, they say that BRCA1 increases risk for both pancreatic and melanoma for both sexes. And just generally speaking, why do we have different figures in England compared to, maybe North America and so on?
Yeah, it depends on the cohort of patients that one is looking at. So one of the big sort of UK papers where when we see families, we usually try and recruit families to studies being carried out often by colleagues in Cambridge. So there's the Embrace study, and then there's a sort of international studies as well. They just all collaborate. So it really depends upon the series of patients that are being looked at. BRCA2 tends to be the one more been linked with pancreatic and melanoma. But as I said initially, it was thought that prostate was high in BRCA1 as well, and there has been a more recent study suggesting a slight increase, but not certainly is not as high as BRCA2. So it really depends upon the series of patients who are being studied, and often that's why a range of cancer risks is given in information, and even within a family, there can be quite between different families. Some families, as I said, have a lot of cancer, and other families less so. So, there may be modifying genes and things as well that are playing a part as to why a certain genetic change is being more penetrant in some families than others.
And along those lines, I've been hearing, I've been a member of kind of BRCA social media support groups for a while, and I do remember discussion around some research showing that it would be possible in the future to look at the specific spelling error on the gene and match that up with specific risks. So, for example, that certain spelling errors would increase the risk of ovarian cancer more, and less breast cancer, and so on. How close are we to kind of being able to have almost a personalized risk figure when we have our genetic testing to know, rather than those big bands of lifetime risks, of what this specific spelling error gives us?
Yeah, I mean, we do know that there's a sort of ovarian cancer cluster region within the gene, so there are those things, but I think it's unlikely, not aware there being those specific things, and all the other factors come into play, like somebody's weight, somebody's age of starting their periods, and age of going into the menopause, and how many children they have had. So the EMBRACE study is really the one trying to tease out all those factors. So certainly going forward, but we know that, for example, for other conditions, like it's quite a common genetic condition called neurofibromatosis type 1, where the same gene in the family and the variability within the family can be very great. So I think there are studies being done towards that, but I don't think we're there yet. I mean, what's good is that we're not only the EMBRACE studies looks at individuals with BRCA1 and BRCA2, but it's also starting to include some of the other genes as well that we identify in families with cancer. So that it's good. It's a big inclusive study that is trying to answer these things.
And I guess part of that message there then is that big range of risks that we're given when we have our genetic testing, that has to, tries to look at all the research that's out there at the moment and different things that could be impacting on our risk. So we shouldn't necessarily assume that our risk is right at the top. I think, like a lot of people, when you get that, you don't look at the minimum figure, you look at the maximum figure. So, for example, I don't know what the minimum figure was on my testing. I know that the maximum figure for breast cancer was 87%, and that's what sticks in your mind. But I guess we need to be conscious of how other things in our life can affect that. So I know you mentioned weight and how many children you have as well. So I know for ovarian cancer, for example, the more children you have, the lower your chance of ovarian cancer, even if you have a faulty BRCA gene. So is there anything else lifestyle wise? I know there's a lot to go that, we talk about lifestyle a lot generally, that specifically does also apply to BRCA mutation carriers.
Yeah, well, just a healthy, balanced diet, and moderate or low, moderate alcohol, all the sort of sensible general health things, really, and trying to keep a healthy weight is important. And just coming back to the ovaries, essentially, if you can sort of stop the ovaries being triggered, that sort of has been shown to sort of help prevent the risk of ovarian cancer. So if somebody's on the pill, that sort of has a protective effect against developing the ovarian cancer. But then we don't recommend that, because obviously the pill's got hormones in it, and that can estrogen and progesterone potentially, and those can increase the risk of breast cancer. So there's sort of pros and cons to things.
Absolutely. So questions along those kind of lines. Someone sent in a question saying they recently had their first child and only found out they're BRCA1 positive now. I've read some studies that show an increased risk in breast cancer in BRCA1 carriers after their first child. Have you heard about this or know anything about that risk?
I think the trouble is that there's the concern about detecting. So obviously when you've had a baby and you're breastfeeding and things, you get lumpy breasts and things. So I think it's sometimes you may not have a lump investigated necessarily as fast. So I think I mean, I've definitely sort of come across some sort of research about that, but I think some of it's definitely related to the fact that you when you're feeding, you get, or having had a baby, you get lots of lumps in the breast, which you may fob off more so compared to if you hadn't had a baby or weren't breastfeeding and things.
But I guess, again, that's to the being self-aware, checking yourself, and always visiting the GP or speaking to somebody if you do notice anything.
Absolutely, yeah.
So another question then, kind of about inheritance then. So I know that a lot of the time, there's a proportion of the time where somebody has cancer and they test positive, they have their genetic testing, they find out that they carry a faulty gene, but they don't have any family history at all. And I know that's fairly common. So it's almost a bolt out the blue that they didn't realise this, and obviously that opens a big can of worms for their whole family. So how is it possible that somebody have a faulty BRCA gene that's causing this bit high risk, yet have no family history to catch it?
Yeah, I mean, some families, they just can with the gene and it's just not manifesting itself. So it's coming, those maybe the families where there is just the lower range of the risk figures that one would give it. It's just, or maybe it's being inherited through the male line. So I mean, this seems to be becoming more of a thing, a finding, because people are having the testing when they are just an isolated case of non-mucinous ovarian cancer, and so we are detected, those patients are being identified with the BRCA gene, and then one of the things, potentially parents have already passed away, but actually there's potentially second cousins and things, so trying to track it back is quite, I feel it's a big important part of our role as geneticists to try and make other people aware in the family as much as possible where the gene has come from, so that potentially they can be offered extra screening and risk reducing surgery if they want it. So we're lucky in that when I started doing cancer genetics in the sort of early 90s, one thought was, do we test the tissue from an affected individual? And then you thought, no, that's not safe, because actually what you find in the tissue is potentially the germline genetic change, but also just the genetic change which is happening in the cancer. But actually now with time, what we're trying to potentially do where people have passed away is actually to try and dissect out the normal tissue in an affected individual who's had, say, a mastectomy, and then do genetic testing in that to try and track back the gene within a family, and then we can try and track more distant relatives. So although it may look as though there's not been the gene hasn't been in the family, it is very likely to have been inherited, but the people who've had it just haven't manifested it.
And I suppose if it's not possible to do that testing on some tissue, you might never know the answer to that, mightn't you? So
no, unless the other thing is we do is pass on a letter that the individual can pass that on to their cousins, and then if a relative on one side has found to have it, it's that side and not the other. So that's the other way, but it's less satisfactory than actually starting, going one straight back.
We've got a question sent in about the CHEK2 mutation, and her genetic counsellor didn't say very much about it in her appointment, so I'm not sure if that person has a CHEK2 faulty gene, or if it's just that they're interested in that and want to know a little bit more about that. So I don't know if you could tell us a little bit.
So we had a big consensus about this with all the sort of genetic teams to sort of work out, if we did a panel, what would we want on the panel, and what would we sort of say if we found that genetic fault. And CHEK2 is one of those genes that was, when we basically BRCA1 and BRCA2 were found, we thought there must be BRCA3. So when we saw families and we did those testing, individuals got recruited to the BRCA3 study, which then became the familial breast cancer study, and then became the breast ovarian cancer susceptibility study. So it was the same study, but it changed its name a few times. And through that study, other genes were found, and one of which was the CHEK2 gene, which we know is a sort of breast cancer predisposing gene, but again, it's a sort of moderate risk gene compared to a high risk gene, which is like BRCA1 or BRCA2. So CHEK2 can be found, and there's one specific variant within the CHEK2 as well, which is more moderate. I mean, it's not something we're routinely testing for on the NHS. If it's been identified in the family, we may well do what we call cascade testing, where we're testing at-risk relatives to see if they've inherited that gene. But it's not, going forward, it isn't one of the genes that we're routinely testing for. If you were to have a breast cancer gene panel, it would be on that gene. So if people go ahead and have private cancer gene testing, then it's often on that panel. But it's depending too, the penetrance of CHEK2 seems to vary. So you seem to get some families with the CHEK2 where there's lots of people who've been affected, other families much less. So it's if you had a family where there was a lot of cancer and the CHEK2 seemed to be the gene predisposing to the cancer in that family, that would maybe, you would be worried about your actual breast cancer risk related to that, and that might put you in a sort of ballpark region for considering potentially having risk-reducing surgery. But often it doesn't put you into that higher risk. It's more a moderate risk.
Okay, so the person who sent that in did send a follow-up saying they have actually tested positive for both CHEK2 and BRCA1. So
yeah.
In terms of someone in that situation, because I do quite often get asked this, is whether you can have more than one faulty gene, and if so, what is your risk?
Yeah. Yes, you can, and so often the genes are working on the same pathway, so they don't definitely sort of up the risk massively, or at all actually. So so it wouldn't necessarily up the risk, but
Okay.
but it'd be interesting to know if the CHEK2 was segregating with everyone with the BRCA1 in the family.
Okay. So a question related to, we quite often get asked questions about the fact that when you're going for genetic testing, it's preferable to test somebody who's affected by cancer in the family. In a situation where someone is eligible for NHS testing and the person with cancer is still alive, if that person doesn't want to be tested and so isn't interested, or they are not willing to talk about it, but one of their relatives who's at risk of the same genetic mutation wants to get tested, what's the situation for that person?
It's very difficult, because we ideally want to test somebody who's affected in the family. If you're doing so the criteria are that you should test somebody if somebody's alive, then ideally you should test them. It is very difficult in some families where the living affected individual doesn't want to have the gene testing. We try and work with the person who's been referred to try and work with that relationship, with their relation, to try and encourage them to go ahead for the gene testing. Because the trouble is, if you test somebody who's unaffected, if you find something that's definitely disease causing, then you've got an answer. But if you don't find anything, what you don't know is whether, because there is something in the family that individual just hasn't inherited, or because there just isn't a recognised gene in the family. So you would still, if you didn't find anything, that individual would still need to have the screening relevant on the basis of family history. So the much more ideal situation is that you test somebody who's affected, find a gene in them, and then test the at-risk relatives, and can say for definite, yeah, no, you've not got the gene, you're not at increased risk, or you do, and therefore put things in place for them.
And I think that's obviously a really tricky situation for you in terms of advising somebody what to do when you're having a clinic with somebody.
Yeah,
because
well, often the relatives are abroad as well. Mm-hmm. So then we might have to try and encourage people who are abroad to try and get the genetic test done and then come back. I mean, there are providers of gene testing who non-NHS, which are sort of relatively cheap, but there just has to be these sort of criteria, unfortunately.
Absolutely. And I think also it's worth pointing out that although it's really useful, and lots of us do want to know. There are people who don't want to have genetic testing, and that is their right equally. And in a situation like that where somebody doesn't want to know, if for example their child was tested and tested positive, they are then telling the person that didn't want to know some information that they didn't want to know, in a way, aren't they?
Yes, no, we definitely don't like to test where there's an intervening relative. We'd always try and do it along the lineage.
Mm-hmm.
Yeah.
So for somebody who, then we know a lot of people on this call know about their genetic risk. If we know that, and we're starting to think about risk reducing measures, so for example having surgery, lots of people get tested, they speak to their genetic counsellor, they go off back into the world, and then they won't speak to their genetic counsellor again unless they have a specific reason to. So once you're ready to go ahead and have risk reducing surgery, who do you speak to? Do you ring up your genetic counsellor? Do you go to your GP and ask for a referral?
It's entirely whatever's going to be most straightforward for you. We would genetic teams would be very happy to make that referral, and often we can give all the information with including the gene report. Often now for the risk reducing oophorectomy and bilateral salpingo oophorectomy, and for the breasts mastectomies, then that we have MDTs, regular MDTs, so any patient having that risk reducing surgery is discussed with a big team, so to sanction that or to not. So it's quite sort of multidisciplinary approach, really. So a geneticist, yes, a GP as well, but genetics, we sort of like to think of ourselves as a GP for rare things. So
Okay.
Hopefully if somebody's been through us, then they can contact us fairly straightforwardly, and that we'll be able to help make those referrals.
And specifically, we've had a question about when someone is going for their salpingo oophorectomy, whether that should be done by a gynaecologist or by a gynecology oncology surgeon.
Yeah, usually it's a gynecological oncology surgeon, but it depends. At most centres would have somebody who's does that on a number of occasions. Generally, when we were doing the UK Fox study, everyone was getting this screening and ultrasound everywhere throughout the whole region, and then actually what we ended up doing was sort of refining it, and just in the Northwest Thames region, just doing it within 2 sort of big centres. So often we would refer to those centres for the risk reducing surgery, but there's certain protocols which are done with risk reducing BSO, where they do look at all the tissue that's removed carefully and do slices to check if there's any occult cancer found when that's done.
Okay.
So there is pathology protocols which they would follow.
Okay, brilliant. That's really useful. A really common question that we get is, and we've been sent in just now, is whether children can be tested, and if not, why not?
Yeah, we do genetic testing in children, but only usually if the result is going to be of use. Otherwise, what's understood and learned is that it's best to allow a child there to when they're old enough to make their own decision about whether or not they wish to find out. I think when we started doing predictive, so what we're talking about is predictive gene testing. In other words, we're saying it's not like a diagnostic test where you've had cancer and then you get the test done. This is a predictive test. So predictive gene testing, it's very much upon the individual whether or not they wish to know. And many young females in the 20s do not wish to find out whether or not they've inherited a BRCA gene. They'd much rather the screening isn't going to start. They don't wish to choose risk reducing surgery. So actually they'd much rather not have that fear of knowing they have a gene, and they'd rather wait until they can actually do something about it potentially. Other people feel very differently about that, but in general we don't recommend that testing. We wouldn't recommend that testing in children, and I'd be very surprised if that was done anywhere, to be honest, because it's not of any benefit for the child to find out. Obviously, if somebody developed a breast lump, then that would be a different, or it would develop a cancer, which would be very, very unlikely. that would be different. That would be a diagnostic test, but it's certainly not something done for BRCA. But when we did start to do the breast cancer gene testing, we would see a family, discuss about having a predictive test. They'd go away, and then we'd send another appointment. But that was recognised to be quite a delayed procedure, and not definitely in the patient's interest. Most patients, if they wanted to know, and I think most people do want to know if they've got a high risk cancer predisposing gene, but it's not in childhood. It's usually, and often girls around the university age and things, it's just not the right time. So we sort of say, we're here, we're happy to see you whenever. Mum's been found to have it, you can find out now, or when you finish uni, or whatever situation is best for you. But most we wouldn't do it under the age of 18.
Okay, thank you. We've got a question. It kind of relates to the fact that we talk about risk reduction surgery rather than preventative surgery, and the fact that there's still a risk there. So after we've had our ovaries and fallopian tubes removed. The question we've got is from someone who's had ovarian cancer and tested positive for BRCA2, and has been told that the cancer could come back. But her query is, where could it come back to? And I think what she's alluding to is, if you've had your ovaries and fallopian tubes removed, why is it still possible to get ovarian cancer? And why is it still possible for the ovarian cancer to come back if you've had it before?
Yeah, I mean, the recurrence, the recurrence of a cancer can very much depend upon the stage of the primary cancer and how the degree and size and degree of spread when the original cancer was diagnosed. But in terms of it, even though individuals can have the risk-reducing surgery, so that's the preventative treatment. So knowing you've got the gene, you're going to have a higher risk of ovarian. So to remove the ovaries and fallopian tubes, there's still a chance that there's cancer can originate in the peritoneum. So we can never reduce the risk to zero. But obviously, it does. The risk-reducing surgery does substantially reduce the risk. But can't take away, and risk-reducing mastectomy can't possibly remove all the breast cells either. So there is unfortunately some remaining risk still, but it's obviously much lower.
And I think that's a really important point that we always try and point out, that even after having a double mastectomy, for example, I still need to make sure I'm checking myself regularly and, speaking to my GP if I find anything. And similarly, if I've already had risk reducing surgery in terms of having my ovaries and fallopian tubes removed, I still need to be aware of ovarian cancer symptoms, and again, know myself and know my body and shout if there's anything wrong. I think that's really important for people to be aware of. We do have a question about having children when you have a faulty BRCA gene, and what are the options around people who are carrying a faulty gene if they want to have children and not want to pass that on.
Yeah, so there's techniques available when you are pregnant called prenatal testing. I have to say this is something that's very, very rarely requested, which is whereby if somebody is pregnant, then after 11 weeks, then it's possible to take a little bit of the placenta to do what's called a chorionic villus sampling, and to do gene testing on that for the BRCA gene. Because that's an invasive test, carries about 1% risk of miscarriage. An amniocentesis can be done after about 15 weeks. Again, that's invasive test, taking the cells off from around the baby. And then you do the gene testing on that. But those tests are done with a view to stopping the pregnancy if the abnormal gene was found. And for many, I don't think that wouldn't be a choice usually that's we get very often for individuals with the BRCA gene. The other technique is something called pre-implantation genetic diagnosis, which is like IVF, and that is available for individuals with the BRCA gene. And so there are certain criteria for that, but essentially it's IVF, it's getting the egg and the sperm, and very early on, when the embryo is at about 8 cell stage, taking off a cell, doing genetic testing on that, and then putting back the embryos that haven't got the faulty gene. It's because the couple isn't infertile as such, they're having this procedure because they're choosing an embryo that hasn't got the faulty gene. The success rate is slightly higher in terms of getting pregnant compared to standard IVF, where the couple's infertile. But obviously it's quite a a staged procedure to do that. And there are certain criteria for PGD on the pre-implantation genetic diagnosis, which is PGD on the NHS. Things like being together for over a year, non-smoking, healthy BMI, so not too underweight because that reduces the chance of getting pregnant, or too overweight, and also one of the things is you're not allowed to have a healthy unaffected child, which can be very difficult because you don't wish to test a child just to show they've got the gene so that you could have a further child through PGD. So there are those restrictions as well. But if a couple don't have children and they're found, say the father, one of the couples found to have the gene, then we would could refer for PGD if that's what they want to explore. And it's for women under the age of 40 on the NHS.
Okay. And it's worth saying that our next webinar that I'm doing next week is about starting a family and options like that. So if that's something you're interested in, please do sign up for that. And we're going to have a BRCA1 carrier on the call as well, who's been through PGD and can talk about the experiences of it as well, to share a little bit what it's like as well. A question that we've had in is about when we talk about lifetime figures of cancer risk, when we've had genetic testing, they always seem to end at 70. So it will say lifetime up to 70.
Yeah.
But obviously lots of people do live a long time beyond 70. So I'm guessing that's due to what the research always used to be. But I suppose what happens to risk after 70? And if somebody has tested positive for a faulty BRCA gene around that age, is the implication that they don't need to worry too much, or is it that they should still be considering risk reduction options?
Well, it's interestingly, so one of the newer papers out by the group in Cambridge is the risks up to the age of 80 years, and that was saying for BRCA1 the risk was 72%, up to 72%, and for BRCA2 up to 69% lifetime risk of breast cancer. So that was raising that risk. Obviously, as I said earlier, the risk gets lower as we get older because we outgrow some of our risk. But no, there is still some risk. But the benefits of risk-reducing surgery versus ongoing screening, you're not going to improve survival by having the risk-reducing surgery. So sort of the age at which many individuals over the age of 60, there's sort of question about having risk-reducing mastectomy. That said, a lot of women over the age of 60 do have bilateral mastectomies for risk reduction surgery still, but that's the sort of cutoff we sort of think about in particular in the MDTs and things. The screening for individuals at high risk stops at 70, but you can get that carried on, and it's about annual mammography, as I'm sure you know, from 40. The MRI is 30 to 50 and annual mammography from 40 if you have a BRCA gene, and that screening can go on over the age of 70, but it's not routinely done.
Okay, brilliant. That's really useful. I think the implication there is that it's kind of on a one-to-one basis as well, that people need to be having that discussion with their genetic counsellor to understand what their risk is at their particular age, and not relying on those kind of big bands of figures, isn't it? So I know you mentioned about the fact that, the most common types of ovarian cancer, you should be getting offered genetic testing. But we know that those guidelines came in, 2015. So if somebody was, say their mum had ovarian cancer, this is quite a common query. Their mum's had ovarian cancer, but they passed away. Can the daughter still get tested? I know you mentioned about tissue samples and so on, but if they don't have that, what's their options?
So if you have a single first degree relative with ovarian cancer, then probably the risk is about 4% over a lifetime. So there is, if you somebody like that wouldn't be eligible on the NHS, but say there were 2 cases of ovarian cancer, then that would increase the risk that individual, so 2 first degree relatives, say a sister and a mum, or mother and a grandmother with ovarian cancer, then the risk of, potentially there's a gene there. Ideally, we would try and identify some tissue from somebody who's been affected, and to do genetic testing on that. So I think it's a single case, you wouldn't be eligible for the testing necessarily, but we would always look into that family history and look into that to the actual diagnosis of the type of ovarian cancer. So there's other causes of ovarian. I'm not sure if you're getting at this, Jo, about Lynch syndrome, which tends to be, so that's another cause of ovarian cancer. Lynch is a cause of hereditary bowel cancer that can be linked with a higher risk of cancer of the womb, the lining of the womb, the endometrium, also ovarian cancer, but tends to be different compared to the BRCA ovarian cancer.
If someone's mum was diagnosed, or anybody really, if someone knows someone who was diagnosed with one of those types of ovarian cancer where they should have been offered testing and they weren't, what should that woman do if she does want to follow up testing? Does she contact her cancer team, for example, or does she try and get a referral to genetics?
Yeah, she should ask her GP, who then would write to us, and then we would review the history and the family history to see if there's anything that could potentially be done.
Okay.
But with that history alone, it might not be possible to do testing, unfortunately. It depends on the family history and things, so we need to look into that. What
okay,
would you have you heard otherwise to that, Jane?
So I would, if someone has ovarian cancer and they should have been offered testing and they weren't,
if they were alive,
they should be able to get in contact if they're still alive. And
yeah.
I think that's we know from some of the research that we've done previously that lots of women either, since the guidelines have come in, haven't actually been offered genetic testing.
If they're alive, definitely. Yeah. Sorry, I was thinking.
No, that's fine.
I misunderstood.
We had a quick question about cancer treatment for women with ovarian cancer and a BRCA mutation. This ties in, I guess, with the idea of why it's useful to know about your status as a carrier if you've already had ovarian cancer, and about specific treatments that are available. So I don't know if you can speak to that a little bit.
Well, PARP inhibitor's been one of the, so yes, it's identified that if you have a BRCA gene, then you're potentially certain types of treatment can be more beneficial, and in particular the PARP inhibitors. So that's why it's particularly useful to know if you have a BRCA gene, because those treatments have definitely been starting to show that they're of benefit for those individuals, and which is often why the gynecological oncologist is wanting to find out very early on, which is part of the reason why the sort of mainstreaming genetic testing has been introduced for ovarian cancer, in that when somebody has ovarian cancer, if you can find out that early on, it's an area, it's a certain treatment that can be of benefit, and that's
sorry, go on.
And that's also not necessarily even if somebody's got a germline, but if actually the variant's just found in the ovarian tumour itself. So there have been studies being carried out for that.
And that's an important point, I guess, as well, is that we are speaking here about germline genetic testing to find out if every cell in your body has this spelling error, but we can also test tumours and find out if that spelling error is in the cancer cells themselves, can't we?
Yeah, and those two have been shown to benefit from PARP inhibitors.
So PARP
inhibitors, like some of the companies have been, like AstraZeneca and things have been helping when there was a sort of big surge for the testing to try and help with those, and in the studies where patients were being recruited.
And that's why I guess it's so important for people who are going through treatment to find out, and because it allows them to have access. So certain PARP inhibitors, which are a targeted therapy, and we hear from our supporters that compared to chemotherapy, PARP inhibitors can be a lot easier to deal with, and they're actually lengthening your life. They might not be reducing the cancer in your body, but they're stopping it grow more. So it allows you to have greater period of time between chemotherapy. And although there are some side effects to them, they tend to be a bit more easier to deal with than the chemotherapy as well. And what's really good is, and we're getting involved as a charity, lots of charities are getting involved with the NICE appraisals of these drugs. So there's always appraisals of different PARP inhibitors going on, to try and get greater access for women. So olaparib, for example, women can now access, if you have a BRCA mutation, you can access olaparib as a first-line treatment, but there are other options as well. So there's rucaparib as well, and niraparib, which are actually available to BRCA positive and BRCA negative women, and that you have to have already been through chemotherapy and had a recurrence before you can access those ones. So there's lots of more information about PARP inhibitors on our website, and specifically about ovarian cancer treatment if anyone is interested in that side of things. I did mention at the beginning that we would allow some time if anyone on the phones had any questions, and because it's coming up to 5 minutes to the end, I don't know if Tori, you could unmute anybody on the phone, and then if anyone has a question on the phone, they can shout it out. If not, that's absolutely fine as well, no pressure whatsoever.
There is a phone that's come up.
That's all right. If you've not got a question, that's absolutely fine. Just wanted to give you an opportunity. But as I say, we haven't managed to get through every question so far anyway. So if anyone does have a question that we haven't had a chance to answer, or something else comes up in the meantime, or at a later date, please do get in touch. It's bracket@ovarian.org.uk. I think we're coming up to the last kind of 3 minutes here. So very, very quickly then, one more question, Angela. So someone's asked about the significance of a TP53 mutation that's found in an ovarian cancer tumour. Is this something that is like BRCA and can be tested for, or is this kind of a different topic altogether?
TP53 is a gene that is very commonly changed in the cancer pathway. So it is, if you look at tumour tissue, you would often find a TP53 variant, but a germline TP53 variant mutation causes something called Lee-Fraumeni syndrome, which is a high-risk cancer condition associated with a very high risk of breast cancer. And it's something we test for in certain patients. It's rare, but if somebody, for example, has breast cancer under the age of 30, they routinely get TP53 gene testing. We also consider it testing for this in families where there's certain family history of things such as sarcomas and other tumour types like brain tumours and things like that. So it isn't, when we looked at the panels of genes, as I mentioned earlier, about if we were doing a consensus, if we were to have a panel of genes, we did include the TP53 gene, but it is a very high risk gene, and yes, it can be associated with breast, but usually other things.
Okay.
Which makes, so it's certainly not a routine gene that we currently screen.
Okay. So I think everyone will agree that it's been really, really useful to hear from Angela today. Really grateful, Angela, that you're able to come on and help us with all those questions. As I say, if you have any others or we haven't managed to get to your questions, please do send them to me. Please sign up for the e-newsletter. I'll send the link round with a roundup email from this, and when we've got all these questions kind of answered for you, so you don't have to have looked at any notes or anything like that. We'll send those round. And again, have a look at the list of other sessions that are on in the coming weeks. We're going to be adding to those all the time, and hopefully it will have lots of things on there that you'd be interested in. Or if you've got any suggestions of what webinars you'd like to see, or any specific topics related to BRCA in general, ovarian cancer, anything like that, please do get in touch, because we want to make this as useful as we can for everybody. So we will send round a really brief survey just to get a little bit of feedback on this, because we want to make these sessions as useful as possible for all of you. And that's one of the reasons why we've done two slightly different setups this week and last week in terms of BRCA, to see what works best and what people prefer. So please be very honest. Send us any thoughts that you've got along the way of how you'd like to see this done, or any suggestions of topics. But thank you everybody so much for logging on and listening to us. And I hope it was really useful. So thank you very much, and thanks, Angela.
Thank you. Thanks. Goodbye.
Bye, everybody.